it's one of those, I think in some sense, inevitable circumstances. But what I liked is what you were saying, what there is that could physician play a constructive role? I think very much. And that's one of the things that I think is so disheartening about the medical community over the last 15 years, is that it's been a completely reactionary to health policy. Just when it seemed like something was going to be deeply problematic for them, then they said, no, don't do that. But they're not really offering a lot of alternatives. They're not really like pushing forward ideas. And I think they can be a great intermediate that because they understand the research, they engage with it all the time. But at the same time, they also deal with practical medicine. They're there during the day, they're there in the clinic. And so they can at the same time, in some sense, translate the research to the policymaker and say, this is what it would look like in real time. This is why it would work, and this is why it wouldn't work, and here's what we can do. To go to what I think was your last question, do I think different countries with politicians in different conventions do a little bit better? I think that's probably a 2, maybe 3-course question. And so I'm going to punt on that one. But certainly the nature of political systems bears heavily into this. But America is what it is, and so we deal with what we got.
I'm going to catch the ball that you punted.
Okay.
To the following extent. First of all, I think everybody in the audience was sort of less informed because you haven't had the opportunity to become informed. In organized medicine, there is at least one organization that does exactly what Wendy is suggesting, and that happens to be the Association of American AAMC. For almost forever on the forefront of dealing with the complete nature of medicine. But in terms of catching the punt and running it back, catching it is not as good as running it back. What do you think the differences are between some of the equally developed countries in this world who do have robust programs where they have adopted the concept that healthcare is a right and not what makes them? Is there anything that you could point to in terms of your research, in terms of your thinking, that makes them different, less, and the answer should be less than
So it's critical system, and so if you're a parliamentarian system, you have much more flexibility in terms of implementation. Just for some extent, you have a 5-year window to operate and to do something to prove that you're effective. And if in that 5-year window you haven't impressed the voters, then you become kicked out almost inevitably. Whereas in the U.S., we have our checks and balances that we're very proud of. But that's both offensive and restraining at the same time. And so we're always in this tug of war on any time we put forth policy change. And in fact, the tug of war usually regresses into just an exchange of pompous political attacks. They just kind of phrase things in very silly ways that are not constructive. Similarly, I started with the comment on the Supreme Court. That's a fairly unique American thing, that we have a very powerful Supreme Court. Lots of countries have them. But here, the fate of healthcare that was passed through Congress, Congress that was elected by voters, may be struck down by 9 individuals. To get a little bit more to Dr. Chamber's points, when I've interacted with particularly my colleagues in Europe, so that would be the other country that I know fairly well compared to the U.S. in terms of the healthcare system and the research, they've always impressed upon me that their governments want to be very closely connected to their leading researchers. And so they don't like to make a move without it being nicely informed by the leading scholars in their group. And I think part of that relates back to the nature of the government as well, which I think that if you, again, given this 5-year pass, we can really do almost what you want. I mean, they're balanced actually. But they don't want to make the wrong moves, because if you make the wrong moves, you can just almost count on being kicked out in the next election. And then you go into the backseat for 5 years while another party is able to kind of move on their legislative agenda. And so I think there's a decision for politicians of whether or not they want to be informed by the scientific community, as opposed to they want to pander to the inaccurate beliefs of the public. But then similarly, in the nature of our elections and political system, I think it becomes very complicated to move forward in any sort of meaningful way. And I think this is a problem that we've returned to for roughly 80 years in terms of healthcare, that every time we try to move forward in any sort of non-incremental way. And to be fair, the ACA, for all the changes that it had, was still fairly behind a change. It was far less ambitious than what a lot of people are doing. But because of the nature of our politics and our political system, I think it becomes, there's more tension between the scientific community and the political community, whereas in the I feel there's not tension at all. In fact, they're joined together, they're gravity towards each other, each rely on the other.
So are we dealing with a rugby paradigm or a football paradigm? Any further questions, Brad?
Do you think more conferences like that, where academics like yourself, clinicians, officials, and advocates are talking face-to-face in the same room would help remedy this problem?
Absolutely. I mean, I think that's, again, to me it's a little bit striking that I've been around, I've been as far as Beijing, I've been around Europe, I've been most of North America, like giving different talks to different things, but that was a completely unique circumstance. And when I talked about it to colleagues and mentors and peers that have been doing this for far, far longer than I have, they too were like, why not? That's really good. And so I think there's an opportunity to kind of engage all of the different stakeholders from multiple different backgrounds. They're all contributing to this larger, a more pristine, we call it, policy. But to be fair, we don't do it that often. Go ahead, Rose.
Sure. My question comes from consideration of the younger generation. For some of us here, we're just entering the medicine students and kind of getting used to what this is like. And this is one of the first times that we're considering a perspective that isn't directly clinical or something. And we're just kind of starting to understand how can we get the message across to maybe students in our high schools, younger generation that are starting to understand, maybe they want to pursue a career in medicine, don't quite understand the broad perspective.
That's a good question. To be honest, I have not contemplated how to do that, because I had set them in a modern school and trying to get this information across to PA students, both through the courses that I've had the privilege to teach, but also when it comes to, as the GPD programs are always revamping its curriculum, always looking for new ways to pursue it, new ways to expand it, and to enrich it. And so I certainly kind of thought, how do you move up one step further and start expressing the classical student. But I think it's a very interesting idea. I mean, because it, at the very least, if you just play out the thought experiment, it would change how people view medicine, both when they interact at their individual level when it comes to taking care of themselves and interacting with other people. It also would change people who want to go into medicine, when they start thinking about disease in this different way. It's interesting. Maybe you can answer.
We've got two more questions.
I have a response to her, actually. I would actually, even if they're not set on applying or becoming a physician, I would actually
No, Dr. Rich is a physician. He
sorry.
decided to do other things. He's not a clinician. And he's not a clinician as of now.
Great. So my point is that I would still encourage them to apply to GPA because this way they can have these privileges that GPA gives, and still they give them as
There's one big question that you may not have an answer to, but how soon do you see this integration between physicians and healthcare lobbyists take place? Because from my personal experience, a lot of physicians see the need for integration, but they're very so I don't know.
The integration was.
Between like physicians and healthcare lobbyists, kind of because you said that.
Well, physicians have this. They have a lobby group.
But
So you're asking for the policy advocates in a broader sense, you know, maybe carrying out these type of things as opposed to something else. I think you're right. To some extent, they seem to have towards it, but I think to another extent, which is part of one of my comments in the presentation, was if inaction is the choice, then I think that they're going to ultimately be forced into action. Change is expected, and so we are on an unsustainable path, both in terms of our healthcare spending, but also deteriorating health standards. And so at some point, big changes are coming. And even if the Supreme Court upholds the ACA as is, it's only the start. Because right now our health problems are outpacing our policy. And so I think it's in the medical community's best interest, which again is why I'm always so excited when I hear about past GPA students I have that are going on to both engage in health policy and the legislative process. They're picking up additional credentials and academic degrees related to it, because that now you can be, you can overcome the inertia like your generation as you come into this. A lot of it because you've been exposed to this during your time in the GPA program. A lot of people don't do that in their different environments. And so you guys can help kind of guide that to overcome, apathy and indifference. Otherwise, the medical community would be caught in a situation that they don't want.
Yeah, I was just telling this back to physicians. What's the risk in considering non-health consequences? Is there the possibility of being too grim injured with the patient, where they start considering, if they see diabetes as being even worse than it is, so they start considering more extreme options to cure diabetes rather than just dealing with the outcomes?
Well, it's an interesting idea. It's what kind of cost trade-offs are to this extensive knowledge. I still would wager that there would be an offset. I mean, this is an empirical question. We can find this out. But I still think there would be offset by the gains of the new appreciation for urgency and kind of the impetus for action as opposed to delaying the changes in health behavior, self-investments, and just medical management more generally by always thinking, well, if I may have a bad heart in 20 years, but for now I'm okay. I think the knowledge, while maybe troubling initially, that cost could be overshadowed by the benefit. They may be more likely to change behavior, and also importantly, more likely to try and improve the behaviors, particularly of the family and the children. Because that's one of the things that we're really struggling to overcome is we see these startling trends among Americans youth, but we just don't have a good way to reverse them or to, at the very least, suppress them. And it's because it's very hard to engage the child in trying to express these complex ideas to them. But similarly, we're not getting sufficient buy-in from parents or guardians and so on.
Willie and then Brad.
I have a question. It's not cost and as a result. And also because physicians are relatively disconnected to the cost of whatever they prescribe or whatever sort of treatments they give, that there's really no sort of check and balance in terms of checking costs. And you mentioned a lot of when you're trying to treat patients, you have to look at everything really holistically. But when you look at the system, I feel like, is there anything that you can do in order to, I guess, integrate the process so that Americans, or just change the mindset of Americans, so that they consider marginal costs of what they do as well as the marginal benefits?
So changing the mindset of Americans may be a little bit too ambitious of a goal. So, I mean, what we're kind of seeing with larger legislative movements is changes in cost sharing. So trying to get people away from like what they call first dollar coverage plans, where premiums are very high, but you also then have cost sharing. We're acting more towards heavy cost sharing up front to try and create better, more judicious utilization, and also a better selection of clinical care. But the other thing that you brought up, which is I think one of the most relevant things, is really an element of price transparency. So patients don't know what their care costs, and typically the physicians don't either. And those aren't easy things to answer. It's not like McDonald's where you can set up a menu and say, appendectomy, this is what it costs. Because what it costs is driven by your type of insurance and the arrangements and the contracts that are made about that. How many different providers see you, whether or not those providers are in network or outside of network. Which pill number you get. So if you're a Tylenol number 2000, there may be another discount involved. Similarly, if you're Tylenol number 1, you may pay the highest price. So there's all these complex arrangements that make knowing the price for any one given episode of care very difficult. And similarly, and this is where a lot of physicians have kind of pushed back on this, because there are some initiatives to try and add price transparency. But a lot of physicians have made, I think, reasonable claim that I don't know how much care they're going to need up front. So when they walk into the office, I can't, assign a dollar value to them straight away. That a lot of it's going to happen after I know more about them, after I assess them, or after I give my medical judgment. And so what I think a lot of the shift is going to be, and England's experimenting with this, the US is experimenting with this, we're trying to get these pay-for-performance mechanisms to take care of those things. Pay-for-performance is a very mixed record and has been completely lackluster. So, pessimistically, I don't think it's going to do much. But that's the type of things that we're trying to deal with. But, and to tie it into this lecture, so that policymakers are getting more concerned about the implications of these various diseases. So they're saying, you're not only costing us money because we're going to spend all these extra dollars on Medicare, Medicaid, and private insurance, but now you're telling us that as a society, we're getting billions of dollars of damages essentially on all these different domains of life, and spillover effect. We have to do something. And so then you may get a reckless policy procedure, pay for performance on steroids. And if the right people are not part of that dialogue, that discourse will be dominated by people who are just seeing numbers, which may or may not be credible. And then there you go. Now you have a new healthcare delivery. Really not going to be good. It's another question.
So, remember we said that this is a very complex, multi-factorial issue. To me right now, education, especially medical school education, is one of the big concerns. And I think given your team, I would really appreciate that we were able to be exposed to all these things from the beginning of college. But I'm concerned that we're never really exposed to this as far as we can tell in medical school. And it's kind of an issue that future medical professionals in the next 3 years when we're possibly graduating, there's 4 of us here at this time. And I think that if this issue is a real issue, what do you propose to do to make this kind of like forward education? Do you think that it could be resistance from traditional medical curriculum?
So I would say that resistance would not necessarily be that the current faculty and those designing the curriculum don't think that this is important and interesting things that have practical implications for training physicians. might be able to find some unique opportunities by collaborating like this for public health. So I know a few other medical schools that in recent years have tried to tear down any silos between like the public health school and the medical school and started saying, you know, we think our public health students could benefit from some medical coursework, and similarly we think our medical students could benefit from some public health coursework. So what can we do to get those together so that both students are going to be enriched and better off as they go through their careers? So that doesn't mean that it's any easier to do that, but it does mean that those like USC might be in a unique position to take advantage of the existing resources in order to try and overcome these otherwise challenges that every medical school face
Right.
So you mentioned how perhaps the most practical application of these discoveries and this growing literature is fighting apathy. And I was wondering if you had considered reaching outside of the clinic to get this information to people in a more preventative manner, like in public education, for example, or public service announcements.
Mm-hmm. So you're thinking, what if you bypass the physicians altogether and go straight to the people and then make them aware of these potential threats to okay. Yeah, so a few of the individuals that I encountered there at the Capitol for that presentation, that was exactly what they wanted to do. Like they wanted to create some community awareness initiatives and go into schools. They wanted it to be a part of a lot of schools are trying to embrace the idea that either once a week or once a month there's some sort of like health curriculum, and so they wanted that to be applied. They wanted to be able to send materials home to the parents and say, you know, we know it's hard to eat right and prepare the right meals for your kids, but here are all the ways it's important, not just their health when they're adults or beyond, but it might actually matter for them as their students right now, graduates, in grade school or junior high or high school. So I think your intuition is certainly important and worthy of more.
Okay, well, Dr. Richards mentioned an operative word. The magic word for the moment is one, to thank him again. There's another word called food. And right outside this room, there is food that will begin to decay if you don't start eating. So